mental and behavioral health conditions, again, more common in autism. And I will tell you, I get frustrated as a clinician when a child comes to me and in their chart, there's a list of psychiatric comorbidities that's this long, because people have just kind of attached these diagnoses willy-nilly across as they come in. And really it's trying to sort out, we know they have an autism spectrum, they're on the autism spectrum, and then what are the key, maybe these key additional co-occurring conditions that might be driving the behavior versus giving them everyone, known to man that aren't going to be all that helpful. And again, it evolves over time for sure. But I think that's something our field needs to do a lot better job of, is really trying to not just slap things on as we go, but really looking more specifically and making sure that we're not, if we're replacing one, trying to really pull out the other and make sure that's well explained to the family. And not just slapping things on kind of willy-nilly, which I still see. So when we see behavior that isn't responsive to traditional therapies, again, we have to think about those both medical and psychiatric co-occurring conditions. I always like to rule out medical conditions to contribute to distress kind of first. And when any patient comes to our emergency room, they get a medical rule out before they go get their psychiatric evaluation if behavior is the concern. And we have improved and improved and improved. I feel like initially, 25 years ago when I started in Cincinnati, if they came in with behavior, it was behavior and people weren't looking at, were you constipated? Did you have strep throat? Like, were there other things going on? And they've gotten so much better really doing a medical rule out. And that's not that they draw labs on every patient. I mean, if they're not having symptoms and that the family isn't worried about pain or something, but they just feel like they've had some other changes or truly stress, having major stressors maybe that have impacted the whole family's coping. They don't have to necessarily do that, but they are more likely to they're going to ask the questions. Are we having normal bowel movements? Have we had any change in urinary continence? Are they eating okay? Are they drinking okay? And going through at least those basic things and checking the ears and looking down the throat, and doing a nice rule out. And we have people to support so that they can get those rule outs before they go on. And then it takes, observation of symptoms and a good evaluation to diagnose and then effectively treat. So really looking at those is super important. And then I mentioned when we get the really severe levels, so we are seeing more catatonia in autism than we've ever seen before. And part of that is I think that we're recognizing it, but the other part is I think that it's also increasing. And so I just got notified before I talked today that there's a young guy in the ED, and he came in for a psych eval, but they are actually thinking catatonia might be it. So he'll come medical first. We'll do the stabilization medically, and then he'll go over to our psychiatric unit typically after that. And so, and I know his name, and he's been in before, and you learn a lot watching kids evolve and how catatonia evolves over time. And then we've had some of our patients be so severe that they've actually needed ECT. And we have some access to that in Cincinnati, but we're needing to build more access to that because we draw from a wide region, and we're getting a lot more treatment refractory behavior. And they've had really good behavioral treatment, really good medical treatment, really good psychiatric treatment, and they're still really, really struggling. And again, these aren't families who have failed these kids. These are really, really challenging kids and young adults who need a really comprehensive approach. And so it's not just behavior, it's really, really complex distress that these individuals are going through.